All right, so judging by Gilly's quick handoff, I'm going to guess that we are saving all of our Q&A for the end. So if you have questions, write them down. Don't forget them. As Gilly mentioned, I will be talking a little bit about some of the shared measures that we put together for the America Serves model. I won't be talking about all of them because there's a lot of them, but I do want to talk a bit about some of them, especially thinking about what do they mean, not just mathematically, but also in a managerial context as well. What do they mean in terms of real world work? So I'm going to start this presentation with a semi-fictitious story. It is not a real person's story, but it is a story felt by many real people in our work. Then I'm going to briefly review some performance measures in the care and service delivery fields, go over this study's methodology, provide some preliminary results, and then go on to next steps. And for the record, this is early stage research that we've been working on for a little while now, and I'm excited to present it to you all and hope you all find it interesting. So I want to start off with Anne. Anne is this wonderful lady over here to the left. She is a transitioning service member a few months out from the military. She has been on deployment. She has been in some active combat zones. And so she has some needs that reflect that, including financial management, including mental health, but as well she's interested in getting herself involved in education and getting herself involved in physical health care. And so while she comes to America Serves to speak with us coordinated care, they're talking, they're having a great time, and they realize, you've realized this physical health care need, this mental health care need, this education desire, and money management desire, and I want to distinguish those as desires and needs. But we've also got this benefits need that's kind of latent as well, right? Like you were coming back to the civilian side with some experiences that enable you for benefits that you have earned, and so let's make sure that we're covering down on that as well. And so Anne goes to this navigator, then this navigator does an intake to figure out sort of holistically what are all those different needs, and then that navigator starts the process of figuring out like who in the community can connect them to those different needs, as Gilly suggested. And so the second half of her journey has varied results. Anne takes a couple of weeks, but she finds a doctor that she likes and who offers the care that she needs following her transition. The navigator also quickly connects her to a local budgeting class in just a couple of days, so she's excited to get involved in that and start learning how to manage her money more directly and more firsthand. She also gets connected with her county veteran service officer that helps her submit a benefits application, but that VSO does warn her, hey, these things often take several months before the VA gets a reply back to you for what your benefit status will be. She also applies to a local community college and is looking forward to starting classes in the next month. And she's still going through this process of finding a mental health care provider. She's met with a few at this point, but no one quite seems to get the military experience that she's had, and she feels that that is a breaking point for her. And so the question that sort of Gilly alluded to here is, how do we evaluate coordinated care networks? And we have come up with some at least preliminary ideas for how we can compare these networks. And that's the other word that I want to keep in mind, is compare. Because it's not just looking at how has this network improved over time, but it's also looking at how do networks compare against one another, right? Like if network A over here is doing a great job, how can we encourage networks B and C to follow that footstep? So that's a harder question than it sounds, by the way. But starting with some work in performance metrics, the first point I want to make is that evaluation, as we probably all know, is really context dependent. It's not just this easy thing where it's like, you can compare everybody against the same baseline. And so I want to make this point by starting out with healthcare, right? Like healthcare and mental health, they're kind of similar domains, kind of. They care about a lot of the same things in terms of health. And so we see some overlap between caring about how expensive our services to deliver, how many patients is each provider seeing, like what is that sort of workload? What is the efficacy of different drugs? What is wait time, ER visits, inpatient time, those kinds of things. Mental health is going to care a little bit more about different screener scores, right? Because they're dealing with a wide variety of psychological conditions that they're trying to measure and understand the severity of. They're also going to care a lot more about suicidality because that's really poignant in their field. But then if we look at something like housing, we get a totally different set of measures, right? Like they're concerned with point-in-time counts. They're concerned with literally homeless counts. How many shelters are in the community? How many beds are available in those shelters on a daily, weekly basis? And so trying to think through how can we compare apples to apples across this gets really hard. And so as we looked through this, we were thinking about what is the context of coordinated care networks? Well, as Gilly mentioned, they're generally groups of organizations that are providing different services, which is really key. They are referring clients sometimes who have concurrent needs, maybe even often with concurrent needs. And then these other 2 points about via central navigator organization and common intake are important just to note operationally, right? Like they describe the work of a coordinated care. And so if we're thinking about this from an operational lens, these 2 pieces matter because they define the work of the network and not just the circumstances they're operating in. And so drawing from this, I guess, old study, but very seminal study from 2001, Proven and Millward talked about 3 different levels at which you can evaluate effectiveness. So they described the community level, which looks at things like how expensive to the whole community is it to deliver services, as well as the public perception that the problem is being solved. Like doesn't just matter the numbers, right? Like we've had some conversations today that it doesn't just matter the hard numbers. Does the public believe that you're actually solving things, addressing things? Because public support matters for things like funds down the line. Then we also have the network, like Gilly mentioned, membership growth, range of services provided, are we duplicating services or are we deduplicating them? And then we have measures at the organization and client level. How expensive is it to deliver services to an individual? How easy is it for them to access those services? And what are the direct outcomes for those clients? And it's really valuable, I think, from our perspective, to think about that operational approach. Because as important as every level of outcomes is, if we are trying to speak to the people who are doing the work, the navigators, the care providers, we need to think about like, what are the things that are within their power to directly influence and control and improve upon. And so a couple of contextual things that I want to note is, one, referral management systems, as Gilly has mentioned, have really exploded over the past 5 years. It is a much more crowded space now. There are more technology options than there were 10 years ago, even than there were 5 years ago. There's a lot more development in this space to connect providers together. Also, as SIREN themselves noted, even before that, a lot of the data that we would be interested in using to evaluate these networks is already being collected as part of standard operations. Now, in healthcare space, we're still growing our ability to collect social care and social needs data, but in the coordinated care space, they've been thinking about social needs for a while. And then finally, organizations and staff have greater control and can respond more quickly to data that's related to their daily operations. And so if we are thinking about, how can we act more quickly, more responsibly, we need to start with the data that is in the hands of the people who are doing that work. So what metrics already exist? Well, we have 5 categories here: quality control, demand, supply, referral, system impact. These come from a study from my colleague, Michelle. And the ones that I really want to focus on for this study are these referral metrics. And so these are, as Gilly noted, counter-objected referrals, which is that sense of accuracy. How long did clients have to wait before their services began? Because we know from a client perspective, wait time is one of those very emotionally significant things. If I have to wait 24 hours versus wait 1 month to get a response, that impacts me and other things can unfold during that time. Finally, were those referrals resolved? Did they result in services at all, or did that client essentially fall through the cracks? So the 2 objectives that we want to think through are, can we identify distinct performance patterns among these networks based on these referral metrics? And then can we generate recommendations for practitioners building out their evaluation efforts? So for this study, we are looking at AmericaServe's data. You never would have guessed that, I'm sure. It's over the time frame of 2015 to 2023, so about 8.5 years of data using Unitas. We're looking at 11 networks, and all told, there is about 30,000 clients in this data set for 70,000 requests. So the 3 metrics, as I mentioned, time to service, which is the time and days between when a request started and the client received a response. There's also accuracy, which is whether or not the first request was accepted by a provider. And we focus on the first request because we notice that the more requests it takes, that might be an indicator of the complexity of the case or the inability of the network to provide care. And then finally, was that request resolved? Did it provide services to the client? And so sample descriptives, you can see there's quite a bit of variation in terms of how many requests each network got, and that sort of reflects their age more than anything else. So older networks obviously have more requests than more new networks. But otherwise, in terms of accuracy and resolution rate, they're pretty consistent across the board. And that, I think, stems from the evaluation framework of IVMF trying to push and facilitate this level of achievement expected of all the networks. And then median time to service can be pretty variant because, well, not everyone provides the same services at the same levels. And I don't mean standard, I mean demand in that regard. So not every network has the same distribution of services. So preliminary results, we did find that there are distinct patterns of performance. The one I want to highlight is this little set of crosses that are in the corner, and we call those well-rounded. We don't think they're stellar performers. We don't think they're the cream of the crop, best people. They're doing everything perfect all the time. We think that they are performing higher than the rest, and we are curious to learn more about why that is. The other groups then come out. We have low accuracy, and low accuracy is still pretty high. Like they're working above an 85% rate. Low efficiency is at a 4 time to respond, and the low resolution folks are below 60%. So it's not that these networks are doing their job poorly, it's just that they're doing their jobs differently, and we want to understand why those differences are emerging. And so, again, this is early stage research, but one of our hypotheses is this correlation matrix here. I did it by network because I wanted to be a good statistician. But the bottom is really where I want to draw your eyes to. And that is the fact that we have significant but weak correlations between these 3 referral metrics. So the time to service to accuracy is just 0.08. Being fast does not necessarily mean you are accurate, and vice versa. Likewise, for time to service and resolution, being fast doesn't necessarily mean you result in services. Now, accuracy and resolution, there's something going on there, right? Like getting the first one right seems to have something to do with whether or not a client receives services. And maybe that has something to do with better knowledge of providers, better connection and trust between providers, but we're not sure. But the key takeaway that I want to drive home here is that this weak correlation is probably indicative that not only are these 3 metrics important, but they're distinct, right? So these reflect separate goals that a network has to simultaneously attempt to achieve. And so for practitioners, what we recommend is first decide your network goals, because if these 3 metrics are all kind of weakly to moderately correlated, it suggests that you have to dedicate specific effort to achieving each one. Then the rest of the stuff is pretty obvious to the rest of us in the room, but collect data that reflects those goals, review procedures on a regular cadence in relation to those goals, and make sure that that aggregate performance ultimately builds from small daily efforts, and then revisit your data framework on a regular basis. Like we heard earlier today, we kind of have this inclination of what is the zig or the zag once and for all. But in reality, we need to think about revisiting our assumptions, our decisions every so often, because what we decided 10 years ago, 5 years ago, 1 year ago, may not necessarily be what we need to keep doing. And so, next steps, we're going to keep exploring the distinctiveness of these metrics. We're going to examine variations arising from service differences, as I hinted at. A network that deals with a lot of food service requests versus a network that deals with a lot of housing service requests probably have different experiences navigating. And then we are hoping to develop a framework to compare networks against each other. But that's all I have for everybody today. Thank you for listening.